Hemostasis lesson on anticoagulant therapy. Patients receiving anticoagulant therapy require periodic monitoring because most of the time their effective dosage range is very narrow. Antithrombotic medications include both anticoagulants, which suppress coagulation by inhibiting thrombin and fibrin formation, and antiplatelet drugs, which suppress platelet activation and aggregation. Anticoagulants are best for treating venous thrombosis, while antiplatelet drugs are best for treating arterial diseases. Thrombolytic medications disperse or reduce existing clots and restore vascular function while preventing tissue and organ damage. Warfarin, also known by the trade name Coumadin or Coumarin, is an antithrombotic that is usually taken orally. The prothrombin time, or PT, is typically performed on patients receiving Coumadin to monitor therapy. Blood samples for PT analysis can remain uncentrifuged for up to 24 hours. By contrast, heparin, also an antithrombotic, is administered intravenously and is monitored by the partial thromboplastin time, or simply the PTT. Blood samples for PTT analysis are normally stable for up to 4 hours. However, blood samples collected from patients receiving heparin should be centrifuged and the plasma separated from the cells within 1 hour of collection. Direct thrombin inhibitors, or DTIs, such as argatroban and bivalirudin, are administered to patients who have developed heparin-induced thrombocytopenia with thrombosis, or HIT, HIT. This is a condition that can develop as a side effect of receiving unfractionated heparin therapy. Warfarin is a vitamin K antagonist and works by inhibiting gamma carboxylation of vitamin K-dependent coagulation factors, thereby reducing their synthesis. It also reduces synthesis of the regulatory proteins C, S, and Z. Incidentally, vitamin K is found in foods such as green tea, avocados, green leafy vegetables, parsley, cilantro, dill, cabbage, and broccoli. Vitamin K is also produced by some of the normal intestinal flora. Warfarin has a half-life of somewhere around 36 hours, and therapy is monitored with the PT and the INR. Thrombosis is the formation of a thrombus, or blood clot. Thromboembolism is the clogging of blood vessels by clots that travel through the circulatory system, also known as venous thromboembolism. Pulmonary thromboembolism and deep vein thromboembolism are two types of venous thromboembolism. Coumadin is used to treat blood clots after surgery and trauma, and to prevent strokes in patients with atrial fibrillation. Coumadin does interact with certain other medications. For instance, combined with NSAIDs, or non-steroidal anti-inflammatory medications, which have antiplatelet properties, there is an increased risk of gastrointestinal bleeding. Antibiotics, like metronidazole, increase the effects of warfarin because they decrease the rate of warfarin metabolism, in addition to decreasing vitamin K levels due to the effects of antibiotics on intestinal flora. Diet also has an effect. Alcohol, for instance, the effects of warfarin, alcohol increases the effects of warfarin, which can lead to increased bleeding. The therapeutic range is generally an INR of 2.0 to 3.0, and it can take anywhere from 4 to 10 days to reach therapeutic levels, due to the half-life of vitamin K-dependent factors. Patients with artificial heart valves usually require a higher INR of 3.0 to 4.5. As you can see by the graph, Coumadin has the greatest effect on factor 7, which shows a 50% decrease within 6 hours of administration. Factors 2, 9, and 10 have longer half-lives. Factor 2 requires at least 3 days to decrease by 50%. Coumadin therapy is not without the potential for complications. Hemorrhaging may occur and is usually the result of overdose. Coumadin therapy is contraindicated for women during pregnancy as the drug can cross the placenta. Fetal warfarin syndrome may develop in these instances, resulting in developmental problems for the fetus. Warfarin necrosis is a condition where the skin becomes necrotic. Gangrene and purpura fulminans may also develop in patients with protein C deficiency. Acquired protein C deficiency is caused by either depletion of available protein C in plasma or decreased protein C synthesis caused by administration of vitamin K antagonists. Purple toe syndrome may develop a few weeks after starting warfarin medication, and it appears to be related to cholesterol deposits that cause embolisms in the foot. The treatment for overdose is to replace dysfunctional factors, those that are vitamin K dependent, especially prothrombin. Vitamin K is administered both orally and intravenously. In cases of severe bleeding, fresh frozen plasma, or FFP, plus factor 2 and or recombinant factor 7 is also administered. This is a picture of an example of purpura fulminans. As you can see in this diagram, antithrombin affects the cascade of coagulation factor activation at multiple points. Antithrombin inhibits the activation of factors 9, 10, 11, and 12, which ultimately prevents thrombin formation. Two types of heparin are available for administration: unfractionated heparin and low molecular weight heparin. Unfractionated heparin inactivates factors 9, 10, 11, and 12. These, of course, belong to the intrinsic pathway. Low molecular weight heparin inactivates factor 10, which is at the beginning of the common pathway. The difference between the two is the size of the molecule and what factors they inhibit or inactivate. Unfractionated heparin is sulfated glycosaminoglycans, or polysaccharides, from porcine mucosa with a very heavy molecular weight, somewhere between 3,000 and 30,000 Daltons. A portion of the molecule has a high affinity for antithrombin. When bound, causes a steric or conformational change in the molecule. This is why it is called an indirect thrombin inhibitor. It has to bind to antithrombin to exert its effects. The effects of antithrombin are accelerated about 2,000-fold when bound to heparin. The heparin antithrombin complex binds and inactivates factors 9, 10, 11, and 12, as well as thrombin. Heparin is used to treat conditions like venous thromboembolism, acute myocardial infarct, after placement of stents, and during cardiac surgery where the blood is recirculated outside the body, known as a cardiopulmonary bypass. So, once the effect has taken place, it is necessary to reverse the remaining heparin in the body. For that, protamine sulfate is administered intravenously, which degrades heparin. As a note of interest, protamine sulfate is extracted from salmon sperm. The APTT, or simply the PTT, is the most common test used to monitor unfractionated heparin therapy. The PTT test is inexpensive, easy to run, and automated for faster turnaround times. A PTT should be ran prior to starting therapy to get a baseline value and determine that the PTT is normal for the patient. If it is not, it could be due to lupus anticoagulant, an antiphospholipid antibody, or a factor inhibitor or factor deficiency. In these instances, if these instances are present, then patient monitoring should be switched to the anti-activated factor 10 assay. This assay enables the measurement of plasma heparin levels, both unfractionated heparin and low molecular weight heparin, and to monitor anticoagulant therapy. The ACT, or activated clotting time, is a point-of-care test and performed using a whole blood sample, and was described in the last lesson. This point-of-care test can be performed at the bedside or during surgery. In order to monitor unfractionated heparin with the PTT, a baseline PTT is determined before administering the unfractionated heparin. A platelet-poor plasma specimen is required and is obtained by double centrifugation. The specimen is centrifuged and the plasma aliquoted into another tube, which is then centrifuged for a second time. This is done because platelets release platelet factor 4 from their alpha granules, which is a natural inhibitor of heparin. Another PTT is performed within 4 to 6 hours following the initial dose of heparin. The PTT will be prolonged within just a few minutes of heparin administration. Values should fall within the therapeutic range and is adjusted until it is. A PTT is performed at least every 24 hours along with a platelet count. If platelets are not properly removed from the sample, the PTT will be falsely decreased. The prescribing physician will interpret the results as an indication to increase the dose of heparin, which could lead to serious hemorrhaging. Patients with antithrombin deficiency are not candidates for receiving unfractionated heparin because it is ineffective. These patients are better served by utilizing a direct thrombin inhibitor. Low molecular weight heparin was developed in response to patients who experienced adverse reactions to unfractionated heparin. As the name implies, low molecular weight heparin has a low molecular mass of around 4,500 to 5,000 Daltons, which is about a third the mass of unfractionated heparin. The action of low molecular weight heparin is mainly inhibition of factor 10A. Administration is by subcutaneous injection instead of intravenous. Generally, one injection is administered every 12 hours. It can be injected prophylactically either during or after surgery. It is contraindicated during pregnancy as it can cause birth defects. Low molecular weight heparin acts very quickly, having a rapid bioavailability, which is why venous administration is not necessary. The half-life is between 3 to 5 hours, versus unfractionated heparin, which has a half-life of between 60 and 90 minutes. In addition, low molecular weight heparin can reduce the risk of heparin-induced thrombocytopenia by up to 90%. Monitoring can be performed, but is generally not necessary due to a fixed dose response. Exceptions include patients with coagulopathies, pregnancy, renal disease, or liver disease. The kidneys are responsible for eliminating low molecular weight heparin from circulation. Therefore, renal insufficiency will result in sustained blood levels. Close patient monitoring is required when serum creatinine levels become greater than 4 milligrams per deciliter, or the creatinine clearance is less than 30 milliliters per minute. Monitoring should be done using the anti-factor Xa assay, as the PTT is not as sensitive to low molecular weight heparin. The anti-factor Xa assay can be used to monitor unfractionated heparin therapy. It is a spectrophotometric method measuring a chromogen at a wavelength of 405 nanometers. The reagents contain a fixed amount of factor Xa and a chromogenic substrate specific for factor Xa. The therapeutic range is between 0.3 to 0.7 units per milliliter. The anti-factor Xa assay is measured by spectrophotometry at a wavelength of 405 nanometers. Basically, a standard curve is built using standards with known concentrations of heparin. These are added to plasma, which provide a source of antithrombin. It can also be added in excess to make sure it is not a limiting factor. Factor Xa is also added in a fixed amount. The heparin will bind to antithrombin and then to factor Xa. The resulting heparin antithrombin factor Xa complex that forms renders the bound factor Xa inactive and thereby unable to catalyze its substrate. The next step is to add substrate. Any unbound factor Xa that remains will work on the factor Xa specific substrate, resulting in a product that absorbs light at 405 nanometers. So as you can see, the residual factor Xa activity is what is being measured. The more heparin the standard contains, the less absorbency occurs because of a low amount of residual factor Xa. It is an inversely proportional assay. The same fixed amount of factor Xa is added to the patient's plasma, and absorbency is measured, then compared with the standard curve. Here we have the diagram illustrating the chromogenic anti-factor Xa assay, as described in the previous slide. Heparin-induced thrombocytopenia is considered a serious medical emergency. The mortality rate is around 20%. It is mostly caused by unfractionated heparin, but can be caused by low molecular weight heparin. The latter is usually caused by patients previously receiving unfractionated heparin and results in a cross reaction occurring. The protamine sulfate used as an antidote to unfractionated heparin can stimulate production of antibodies similar to anti-heparin platelet factor 4 antibodies. This results in thrombocytopenia and thrombosis symptoms that are almost indistinguishable from those induced by unfractionated heparin. Platelet factor 4, or PF4, is a cytokine released from the alpha granules of activated platelets during platelet aggregation. It promotes blood coagulation by moderating the effects of heparin-like molecules. A certain percentage of patients on heparin, up to 5%, develop an IgG antibody to the heparin PF4 complex. Somewhere between 30 to 50% of the antibody heparin platelet 4 complexes will bind platelets and activate them. The end result is thrombocytopenia and at the same time generalized microthrombi in circulation. The laboratory developed the 4T's scoring system to predict heparin-induced thrombocytopenia. The 4T's is based on a scoring chart that will be presented in the next slide. The scoring is interpreted as follows. A score of 6 out of 8 indicates a high probability. A score of 4 to 5 out of 8 indicates a moderate risk. And a score of 0 to 3 out of 8 indicates a low probability. See RODAC 5th edition, page 707, table 3917 for the 4T's scoring system to predict heparin-induced thrombocytopenia. The maximum pre-test probability score is 8. And again, a score of 6 to 8 indicates a high probability of developing heparin-induced thrombocytopenia. A score of 4 to 5 indicates an intermediate probability, and a score of 0 to 3 indicates a low probability. The most immunizing heparin exposure is considered first. For instance, unfractionated heparin received during cardiac surgery is more immunogenic than unfractionated heparin or low molecular weight heparin received for acute coronary syndrome. The day the platelet count begins to fall is considered the day of onset of thrombocytopenia. It generally takes 1 to 3 days before an arbitrary threshold that defines thrombocytopenia, such as 150,000 platelets per microliter, is passed. Direct thrombin inhibitors bind and inhibit both free and fibrin-bound thrombin, which of course prevents fibrin formation. Additionally, they prevent activation of factors 5, 8, 11, and 13, as well as preventing thrombin-induced platelet aggregation. Direct thrombin inhibitors will affect the following coagulation tests: the PT, the PTT, the thrombin time, and the ACT. Generally, the PTT is used as the monitoring test. Direct thrombin inhibitors may be administered to patients with heparin-induced thrombocytopenia or when it is suspected. Remember, neither unfractionated heparin, low molecular weight heparin, or Coumadin can be used. The use of direct thrombin inhibitors can reduce the risk of thrombosis by up to 50% for 30 days after heparin is discontinued. Direct thrombin inhibitors can be administered either intravenously or orally. Members of the intravenous group include bivalirudin, lepirudin, or hirutin, and argatroban, or gatroban. They are often used when heparin-induced thrombocytopenia is suspected. Monitoring assays will be discussed on the following slide. Dabigatran, or Pradaxa, is an oral thrombin inhibitor. It has been used successfully to prevent venous thromboembolism following orthopedic surgeries like knee surgery, and to reduce the risk of stroke from emboli in patients with atrial fibrillation. No monitoring is generally required. Atrial fibrillation occurs when the atria, the heart's two upper chambers, beat chaotically and irregularly, out of coordination with the ventricles, or the two lower chambers of the heart. The symptoms often include heart palpitations, shortness of breath, and weakness. The irregular and often rapid heart rate increases the risk of stroke due to emboli, or blood clots, forming in the heart. These in turn may circulate to the brain or other organs and lead to ischemia, which is a blocked or reduced blood flow. Episodes of atrial fibrillation can either come and go or not go away at all, and therefore require treatment. Although atrial fibrillation itself usually isn't life-threatening, but it is a serious medical condition that sometimes requires emergency treatment. Treatments for atrial fibrillation include medications and other interventions to try to alter the heart's electrical system. The intravenous direct thrombin inhibitors are often monitored with the PTT. However, in cases where the PTT is unreliable, such as when lupus anticoagulant or factor inhibitors or deficiencies are present, an alternate test, the Ikarin clotting time, is used. This test was initially developed to monitor patients on hirudin, or lepirudin, an anticoagulant derived from leeches. Incidentally, lepirudin is no longer available. Ikarin is a substrate that is derived from the venom of the Indian saw-scaled viper. Fortunately for you, I will not go into the principle or specifics of the test. But the ECT is prolonged only by the DTIs, or direct thrombin inhibitors, and very low prothrombin or fibrinogen levels. In the last decade or so, new oral anticoagulants have been developed and are now available. Examples include rivaroxaban, or Xarelto, apixaban, or Eliquis, and edoxaban, or Lixiana. These are all factor X inhibitors. Rivaroxaban is the first oral active factor Xa inhibitor. It is approved for use in treating deep vein thrombosis in knee and hip surgery patients and stroke prevention in people with non-valvular atrial fibrillation. Apixaban was initially approved for prevention of stroke associated with atrial fibrillation and can also be used for prevention of deep vein thrombosis and pulmonary embolism. Edoxaban is approved for the prevention of stroke and non-central nervous system systemic embolism. These new anticoagulants do not require monitoring, but they are rather expensive, and no antidote currently exists for them. Aspirin may be used as an oral antiplatelet drug since it suppresses platelet function. Aspirin irreversibly affects platelet function by inhibiting the enzyme cyclooxygenase and by inhibiting formation of thromboxane A2, a potent platelet activating substance that is released from activated platelets. The effects of aspirin on platelets starts about 1 hour after ingestion and lasts for the lifespan of the platelets, which is around 1 week. Aspirin can help reduce the risk of many conditions such as myocardial infarct and stroke due to thrombi formation associated with atrial fibrillation and prosthetic heart valves. Aspirin is rapidly absorbed from the GI tract and reaches peak concentration within 1 hour after ingestion. The dosage can range between 75 and 325 milligrams per day for these conditions. However, a lower dosage of 30 to 75 milligrams per day has been shown to produce antithrombotic effects. Aspirin therapy is considered to produce a fixed dose response, which is to say it does not require regular monitoring or lab-directed dose adjustments. However, if monitoring is desired, platelet function tests would be appropriate.